Welcome. A bit of housekeeping. I won't talk too long, but if you want to pose a question to these lovely two people who are here, you can only do that through the chat function. So lovely Louise is going to be collating that. So I just encourage you to post your questions there so that we can gather them up and be able to talk with Katherine and Stephen. This afternoon, we welcome two great people whose full-time jobs at present are to give advice to government on the needed changes across government portfolios to improve those lives for those of us who are struggling with a mental illness and their carers. Dr. Stephen King from the Productivity Commissioner is here, and Katherine Lourey, the New South Wales Mental Health Commissioner. It's wonderful to have you both here. We'll be spending some time talking about the issues and finding from the Productivities Commission's inquiry into mental health. Gee, that's a big word, mouthful. And to understand, which I understand now, I thought it was to be delivered this week, Stephen, but I understand now it's June, but you'll be able to talk to the audience about that. And there's also been many announcements we've heard from both federal and state governments around mental health. So it's great to have Katherine Lourey here to give her perspective from the New South Wales end, and for all of us to share in that. Before we get into the serious stuff, I thought we'd ask the panellists just one easy question. For those of you who don't know, it's International Tea Day, so the drinking of tea. So my question to the both of you is, what is your preference? Is it coffee or is it tea? Stephen.
Hopefully I'm off mute. Yep. Makes it easy by this. Cup of tea.
Cup of tea?
And, green tea. So.
Okay. There you go. With any lemon or anything, or just plain as it is?
Well, in fact, technically what I'm drinking isn't green tea, it's white tea. But for those of you who are tea connoisseurs and know that white tea can be very expensive, let me say I buy the cheap stuff.
Okay. And Katherine, your choice, coffee or tea?
As it happens, on my desk, I am having a chocolate macadamia coffee with a chaser of French Earl Grey. And it might sound a bit weird, but at this time of day, I know I have to ease back on the coffee and get back into my tea. So I actually have a cup of each at this point in time.
Oh, well, that's lovely. I have not heard of a tea chaser before. So that's a wonderful thing. For myself, in the morning, I'm a coffee drinker, but as the afternoon, I love my tea as well. And you always finish the day on a cup of tea, and it's one of those nice things to enjoy when the children go to bed. So for me, that's a wonderful thing. So I'm going to hand over to Dr. Stephen King, who's going to talk to us. Well, I'll allow him to let you know what he's going to talk to us about, but he spent a lot of time over the last year listening to consumers, to carers, to stakeholders, to professionals, to politicians. I imagine there's been a whole lot of people you've been talking to. So let's sit back and have a listen to you, and I'll hand it over to you, Stephen. Thanks.
Okay, so thanks, Kathy, and thank you to Wandor for organising this symposium, and to everyone who's joined us today, particularly those of you who have lived experience. In the next 15 minutes or so, I'd like to give you an update on the Productivity Commission's inquiry into mental health. We're in the final stage of a report process, and we aim to present the report to government in late June. Now, as Kathy's already mentioned, this is slightly later than originally intended, but as you would all realise, there have been some pretty extraordinary events that have occurred between our draft and our final report. These events have had a direct effect on our report. The current pandemic, coming on the back of the bushfire crisis last summer, has increased the importance of some areas of mental health reform. So the Commission has made sure that it has revisited every aspect of its recommendations to ensure that they have the flexibility required to deal not just with the current crisis, but with any future ones. Now, our report cannot and will not recommend solutions to pandemics and climate change shocks or future financial crises. What we do need to be sure of, though, is that our recommendations can underpin a mental health system that can respond to these shocks. Now, protocol means I cannot reveal our final findings and recommendations today. We must first report to government and then wait for the release of our final report by government. Formally, the report can be released up to 25 parliamentary sitting days after we provide it to government. Now, obviously, that is a somewhat less certain timetable today than it usually is. However, the recent activities by all levels of government show that there is a strong awareness of the need for action in mental health. Nonetheless, I can say that our draft report, the Productivity Commission's final report, like our draft report, the Productivity Commission's final report into the mental health system in Australia will be comprehensive. I'm afraid to say that, like the draft report, it will remain a very, very long read. However, when the final report is released, I think you will see that our thinking has developed considerably since the draft report. In large part, that's thanks to you, the people here at the symposium today, and other consumers and carers, people with lived experience, those who help people with lived experience. We have received an incredible amount of feedback to our draft report through both formal written submissions and through our public hearings. In total, during the course of this report, we have received more than 1,200 written submissions and almost 500 written comments. They're all there on our website if any of you feel like some bedtime reading. This response is incredible. I understand that it is more input than received for any previous Productivity Commission inquiry. It reflects the passion and commitment of consumers, carers, service providers, and others involved in Australia's mental health system. It also, unfortunately, reflects the level of work that is needed to bring our mental health system up to the standard that Australians should all expect. So, what has your feedback told us? I want to focus on two things. First, the feedback told us that our draft report lacked vision. In the lead up to the draft report, we had discussed consumer-centred care and our vision for a person-centred mental health system. However, when the draft report was released, those with lived experience could not see this person-centred vision. Mea culpa. The Productivity Commission brings an economic lens to the mental health inquiry. To an economist, and most of the PC team on this inquiry are economists, it is not simply the case that the mental health system should be person-centred. Rather, nothing else makes any sense. Now, I summarise this in one line that some of you may have heard before. A mental health service only has value if it is valued by the consumers of that service. Now, from an economic perspective, consumer choice must be central in any mental health system to allow consumers to gain the services that best suit them. No clinician or service provider can substitute for the consumer. Now, to an economist, this is obvious. Unfortunately, not everyone is an economist. And in the mental health care system in particular, this person-centred approach apparently is radical. Well, that means that this may be the one report where the Productivity Commission is going to be considered as a nest of radicals. In our draft report, the vision of a person-centred mental health system was not properly communicated. This will be rectified in the final report. In the final report, you will see an explicit vision of a person-centred mental health system. A vision of a system that focuses on prevention, early intervention, and recovery. A vision of a system that supports people to live well in their communities. A vision of a system that provides the right supports at the right time, that is seamless from the consumer's perspective, as they face variations in their mental health throughout their life. And a vision of a system that recognises consumers' preferences and, where possible, meets those preferences. Second, we were told that our draft report was too focused on clinical health care We were told that we had missed the community care that is fundamental to consumer well-being. As I noted in the Grace Groom oration last year, that was the unintended outcome of the status quo. What do I mean by that? It's unintended in that the Productivity Commission recognises that the clinical mental health system and the system of mental health community services, including but not limited to psychosocial supports, housing, employment support, they are simply two sides of the same coin. They must be balanced, and one cannot and should not be placed above the other. It's not an either-or choice. Without both clinical and community supports and the ability of the consumer to choose the services that best meet their needs, there can be no person-centred care. And the role of the status quo? Well, the situation at draft report stage and the situation today is that there is a coherent but flawed mental health care system in place in Australia. This includes GP services, psychotherapy services, acute services, emergency departments, much more. The clinical system has missing services, gaps where consumers cannot receive the clinical assistance they need. It has poorly designed services where the only services available do not meet consumers' needs. It is a system that disempowers consumers and where decisions are clouded by stigma, but it is a system. And in the final report, as in the draft report, we will have many, many recommendations to improve the clinical mental health care system. We will consider every part of that system and how it can be improved. In contrast, our view is that there is no coherent system of community mental health supports. Rather, there's bits of systems. There are disparate groups of services that are funded, then they're defunded with little logic, where service providers face numerous funders, all with different reporting requirements, and where the only consistency for the service providers is the short-term nature of the contracts. It is a situation where coordination is lacking at the highest levels. So consumers and carers face a daily battle just to receive the basic services they need. And even then, for those consumers and carers, there's no guarantee that those services will be there tomorrow. So that's not a system from our perspective. So our final report will have recommendations to create a sustainable, evidence-based system of community mental health supports. It will be a system that is built on consumer and carer input, not tokenistic input, but real consumer and carer involvement in the decisions that affect their lives. Now, these are the two key areas, but the Productivity Commission have heard much more in your feedback. For example, we had evidence provided at our public hearings and in written submissions about the side effects of medications. Not something we really looked at in draft. But we heard situations where needed information was not given and alternatives were not presented. We heard situations where the consumer was disempowered, situations where a failure to inform the consumer and carers about the potential consequences of medication led to loss of life. In some areas of mental health, Australia's medication prescribing is clearly out of line with both the best medical evidence and with consumers' preferences. So we're going to have some recommendations to address this. We've also had evidence presented in hearing submissions and in meetings about individuals facing mental health tribunals without appropriate legal representation and without anyone to even act as their advocate. And we've seen the evidence that the outcomes for individuals, including being held against their will and having forced treatment, differ depending on whether they do or do not have representation. So we're going to have some recommendations to address that. We had evidence provided both before and since the draft report about the lack of integration and care coordination between acute inpatient facilities and community services and facilities. We have visited step-up and step-down facilities that provide these much-needed services, both when a person's illness worsens and when they are recovering. And we have also heard evidence about how that recovery stalls and health declines when the needed community services are missing. So our recommendations will aim to fill these service gaps and ensure coordination of care. In our hearings and through meetings and submissions, we've heard how stigma undermines the mental health system. This includes stigma that locks those with mental illness out of opportunities to participate in community. It includes stigma in the workplace, where unacceptable behaviour such as bullying and harassment continue because those in charge choose not to understand the damage that these actions are causing. It includes stigma in the education system, where adjustments to support students that are taken as given for those with physical ill health have to be justified and fought for those with mental ill health. It includes stigma in the medical system, where a diagnosis of mental illness places the consumer in a clinical box, meaning that comorbidities remain unrecognised and go untreated. And we've heard about the effects of this stigma on individuals who hide their ill health and try to act as if everything is all right because they're in fear of the opprobrium of others while their world is collapsing around them. Stigma directed at those with mental ill health is a social problem. Now, it's not going to be easily fixed. We've come some way in areas such as anxiety and depression, but for people with severe mental illness, such as psychosis or personality disorders, there has been little, if any, progress. Again, we're going to have recommendations to try and make progress to eliminate stigma in our final report. And we've had evidence to illustrate the void of information around mental health. At the individual level, we have heard from consumers who must retell their story over and over as they are passed from one clinician to another, and from consumers and carers who see advanced care directives that summarise treatment wishes just ignored. At the system level, we've heard about treatments that continue to receive government funding, despite little if no evidence of their effectiveness, while other evidence-based approaches that consumers may prefer languish. Our recommendations aim to change the information culture of the mental health system from a culture based on disempowerment of consumers, where they are told that the clinician knows best, to a system based on outcomes as perceived by and evaluated by the consumer, and where consumers and carers have the information that they need to access the care that is right for them. So there are a few of the areas, but as with our draft report, our recommendations will cover the mental health system in the broad. They will cover perinatal services, the education system, workplaces, community services, clinical services. As I said, it remains a long report. Broadly speaking though, our recommendations will fall into 5 rough areas. First, helping people to maintain their mental health and reduce their need for future clinical intervention. These recommendations will focus on prevention, early intervention and recovery. The second set will look or aim to improve people's experience of that mental health care system, to ensure the care received is person-centred, timely, consistent with treatment needs, and does not impose an undue burden on either the consumer or the carers. Third, improving the experience of people with mental illness and their carers beyond the healthcare system. Recommendations that recognise that there are numerous gateways in the community through which people enter the mental health system and a range of services beyond healthcare that are critical to the individual's recovery. Our fourth set of recommendations aim to help people to reach their potential in life, to have purpose and meaning, whether through education, stable employment, or contributing to the lives of others. And finally, we're going to have the boring backroom recommendations that have to be there. Recommendations that will reform the foundations of the system, to reform who decides what to provide, where, when, and to whom. Recommendations to alter the incentives in the system to ensure services for people in need are as seamless and timely as possible. Now, we've got a lot of recommendations. We're actually thinking of, we might change from recommendations and actions and use a few different terms, because there is a lot of them. And we're going to need to prioritise them. So we will have priority lists of recommendations and actions to government. There is no point in presenting the government with just a long to-do list without presenting which issues, which recommendations, which actions are priority, and providing them with a sequence, particularly where one recommendation must be done before others can be implemented. Now, there are some recommendations that will be straightforward, where the reform not only improves services for consumers, it also reduces the cost of the mental health system. Some of these involve technology, while others simply involve new services that increase prevention and early intervention at low cost. Other recommendations will be priorities, because they are foundation stones. They're changes that are needed to build a person-centred system. Got to make sure we get the foundations right. Otherwise, the system will not work. Some priorities will involve significant expenditure. But they are priorities because they lead to large improvements in the quality of life. But not every recommendation will be a priority. Some people will inevitably be disappointed that the recommendation they consider most important is in a nice to have rather than a must do category. However, remember that the Productivity Commission's recommendations are not simply a short-term fix. Rather, what we are aiming to do in this inquiry is to present a generational package of reforms, a set of reforms to guide Australia's mental health system forward over the next few decades. So thank you, and back to you, Kathy.
Thank you so much, Stephen. It's wonderful. I wish I could, you could share the stuff that is closed in that little vault, but maybe see what comes out, but that's wonderful. And I'm looking forward to discussing that a bit more and what you talked about. I'm just going to pass to Katherine, just from New South Wales and where you're sitting as a New South Wales Mental Health Commission. I know that the Commission's done a lot of travel before COVID, but in terms of you went out, you've gone to regional remote areas, you've gone around New South Wales, you've been able to look at services that are here in New South Wales and really been focusing on person-centred. And it's wonderful to hear that from Stephen, but also around lived experience. So, and I just wonder if you can reflect from what Stephen said, but also from a New South Wales perspective and what you're seeing around the need for change.
Yeah, absolutely. And hello to everyone. And I'm always so pleased to be here with One Door. So great on you, Kathy, to get Stephen and me together and separate at the same time. But it is really interesting, and I'm sure that Stephen has also tried to grapple with this conundrum that you know, we've been writing and updating our New South Wales Mental Health Strategic Plan, and last year when we thought we were near the end of it, and then the bushfires began to get worse, we thought, oh, we better pivot and look really at how that's affecting communities. And then COVID happened, and then of course you realise that's on the back of a series of years of drought and other trauma in communities. So it's a really interesting time, and I don't know whether Stephen, you've put it to bed yet, but I mean, you know, only last week we now have a national mental health COVID response plan, which has, you know, 10 principles and 3 key actions, etc. And I think that's the thing at the moment, that how do we deal with change? And so the point around what does a sustainable model look like going forward? I think the first thing is it has to be agile. You know, we have to understand not only around the changing circumstances of the trauma or the mental health impacts and the wellbeing impacts upon our community, but also the economic and financial impacts. So how are we going to get our governments to look at the great work that the Productivity Commission will be putting out to say, okay, well, how can we find our way through this? And so I think having the priorities about, say, the sequencing, I think will be really important. But there will be trade-offs, won't there? You know, and I think maybe it would also be good to, if there was some understanding about which are the trade-offs that can be tolerated and which are the ones that can't be. And I think that was something that really came out through our, you know, visits last year, and into early this year, about 60, different communities across New South Wales, is where those trade-offs are. And we know that we will never have enough money. So it's around how do we get other agencies to come together to be more effective collectively? How do people come in to that decision-making process locally? And I know in the draft report of the Productivity Commission, there were the thoughts about the potential recommendations for local commissioning bodies, and what does that mean, and what does that look like, and really understanding that huge impact that is varied from community to community and region to region. And that's the strength and the privilege of going to 60 different communities, whether it be metro, rural, or out far west, is that you really understand that different communities have different capacities to step in. Other communities have great resources and great community cohesion, but it doesn't always work for everybody. And that real issue around choice, around supports, that connectivity between housing, employment, or income support. We don't all have loving families who support us and are there every day. We have different social networks when we're living in small communities. It also means that issue around stigma might be more palpable in your daily life. So, even if you are in a town where there may be supports, you may not want to identify and reach out. And I think that's the conundrum, how, it's really about that implementation. And I think a lot of those issues, Stephen, I can just so applaud you, especially around stigma. As a country, we don't have a lot of good data on stigma, and what data we have tends to be old, or surveys aren't frequently enough to understand and track changes. And I think you might have self-stigma, which you identified in the services, but I think when that's rolled up with racism, that people will be very reluctant to engage with the service. And when you do look at the evidence around where impact of stigma really has its greatest, I suppose, influence, is those consistent, repeated experiences of discrimination or stigma. And I think when you do have, when I've been speaking with people, especially with severe mental illness, where that gets picked up a lot, even from that first time where someone may use the word schizophrenia. And I think, Richard Schweitzer actually has spoken about this. What does that mean for me as a person, before I even start to think about what does that mean for me and my family and my journey ahead? And I think that's really key. And that came up time and time again, about people wanting a safe space to go and talk about issues. So that's not about, having a hospital, or it's not even about necessarily having a community-based service that will step up, step down, but really a safe space where you have other peers to go to and to talk through those issues, to get you through those times. And especially, I think when you look at the period that both our plans will be implemented, when we're looking at the added stress of financial burden, unemployment, the knock-on effect to housing affordability, that we'll be finding people with existing mental health issues will become a lot more vulnerable, because we know that collectively employment rates are different, education rates can be different. So I think there's a lot there, but I'm incredibly heartened for you to see that some parts of the system are working well. And I always have to keep kind of reminding people that parts are working well, because I do get concerned at times when you hear the system's falling apart. It's absolutely atrocious, because we know today that there will be someone in an emergency department waiting for care, or that someone will be in an inpatient unit, really desperately reliant upon the services that are wrapped around them. That doesn't mean we can't do better, and it doesn't mean that we can't have a more caring and compassionate workforce, but it is that whole mix. And I think so the looking at upstream, the early intervention, prevention, you touched on other issues which I think are really important about health literacy of our workforce. So no matter where someone comes into the system, the person that they're talking to understands mental health and physical health, and then those other social dynamics. So I think, so when we talk about health literacy, I think it's not only the health literacy of the person understanding, the advice that they may be given about their medication, but also of the workforce who may be, a generalist nurse saying, okay, well, here's this medication, but without actually understanding the person as a whole person. So I think that's something that I was quite heartened to hear.
I'll mute myself. Thank you so much, Katherine. I think that's from both of you. And this week we spent a bit of time talking to different people, and yesterday we spent an hour talking with a person with a lived experience of schizophrenia. Katherine, you mentioned him before. He works for both of us, Richard Schweizer, wonderful guy, and Bernie Mullen, who's a carer of a 25-year-old who has schizophrenia. And both of them were touching on the things that you've talked about today in terms of a fragmentation of a system, the different kind of push and pull that you have to go. And it's like sometimes going through sometimes some of the hospitals and their wayfinding and getting lost. The system is very complicated, but their stories in amongst it all were stories of hope. And I think that was something Richard spoke very powerfully about in amongst it all, us having that hope. And I think, and hearing that from someone who's living and breathing it as a service provider and in the position I am, and I think for all of us is being able to go, how do we continue to build on the hope that people have as a whole, and how do we, in terms of delivering the services and structuring it and stuff. So I really, I'm hopeful, I guess, in all this. And I think as a sector, in talking to my colleagues also, we're hopeful that the PC report will be heard. So so there's my little kind of round, but I'm interested because we've got a lot of people wanting to ask some questions. So I'm gonna put some out there, and we'll get them going and starting chatting. I guess I think a question for all of us, and whether I totally appreciate, Stephen, there might be some things you can go, I cannot say that. So I'm happy to, we're all happy and we're all adults here. We can have that kind of conversation. But in terms of being able to go, I think, can you be able to say to us that there's potentially going to be some, what you're proposing is an increase in funding, not just a shifting of funding? And can you give us some highlights of that?
Yeah, so thanks, Kathy. Sorry, I think Gus and I are fighting over the mute button, sorry. So there will be both. And so there are some areas, I keep calling them no-brainers, so much so that the team are now calling them no-brainers, but I suspect we'll use a different term in the report. Because there are areas, and a lot of them are in the community service space, where funding those services actually leads to net savings across the system. It may not be, it may be spending in housing that saves money in health, or it may be one part of health to another. So there are, free lunches, for want of a better word, here. And as an economist, it's a bit frightening to get into a system where you say, actually, just shifting some resources around actually buys you a reasonable amount. But let's not kid ourselves. We will be recommending, in our priority recommendations, there will be priority recommendations that will need significant increases in funding. And when we've looked at those priorities, the frame that we've looked is to really say, what is the improvement in life? What is the improvement in the people, to the consumers? and how do we get the best bang for the buck, for want of a better term, in improving quality of life for consumers out of that extra government spend. So that's one of the factors that's coming into our priorities. It's not the only factor, but it's one of them.
The question from someone watching is, the draft PC report did not substantially highlight the critical importance of the early years, i.e. perinatal, infant and early childhood, nor did it highlight the enormous lack of early childhood mental health services. Should we expect the final report to address this as an area of priority?
Yeah, I'm just wondering how far I can go in sort of signalling what our I won't say what priority recs are, simply because we haven't bedded down the report yet, and I'd hate to say well, nudge nudge wink wink, you can think of this as will be a priority area, and then it drops off for whatever reason and something else becomes a priority. But we are aware of those early years. We went, I guess, probably softly in the draft report, because particularly the 4 school interventions, those between perinatal and school interventions, there are significant groups out there who, for whatever reason, and I don't know what their reason is, it doesn't come through in their claims to us, fight very, very hard to oppose social and emotional well-being checks for preschool kids. When pushed on why, it seems to be a view that, well, this will lead to increased medication. And I think one of the things I'm more than happy to say, the team seems to think that it's one of my bugbears, becoming more aware since draft of exactly the situation with medication in Australia. Believe me, we would not be making recommendations that would be increasing medication, particularly for kids. But that group has been very successful in pushing back in the past. That won't stop us from pushing forward again. And you will see that as part of our recommendations. But our recommendations will include perinatal, they will include social and emotional wellbeing for preschool children, and they will include quite a bit of change from our draft in what we're thinking of in the school setting. And that really comes from a lot of feedback, again, from both people with lived experience, from parents of children dealing with the school system, and from the school system themselves, and finding out much more about what can work and what can't work. So you'll see recommendations in all of those areas.
Great, I appreciate it.
Am I allowed to ask Stephen a question too, or do I have to type it in anonymously?
Oh, no, don't.
I was just going to ask about the perinatal, but also about that the point around the preschool wellbeing checks. And so my question is, in that thinking, were you placing that I suppose outcome in terms of the family, because it really is that family dynamic and the well-being of the family, not only of just a child within that family.
Yeah, and it's trying to make that clear, that what we're talking about, I mean, perinatal is just clearly the mum, the dad, the family, the attachment. Make sure that you've got a functioning unit going on there that can provide the sort of environment that the child needs. And preschool, it is about, if there is a problem at the preschool level, it is going to be a family level problem, and you have to take a whole of family approach. Otherwise, it's just not going to work. The idea, well, we'll take little Johnny or little Sarah and we'll pop them off here and we'll treat them without treating the source of potentially trauma that is leading to the problems, it would just be a waste of time. And perhaps, and again, perhaps, hopefully this will come through more again in our final report and draft, and it's certainly being pressed home to us by those with lived experience. Just that in right through your life. You can't treat mental health as, well, it's something that occurs over here, and you get your treatment, and then off you go back into exactly the environment that caused the mental health problems in the first place, or triggered the mental health problems in the first place. That's just a waste of everybody's time and money and effort. That unless you're addressing the underlying cause, the underlying triggers, you can't expect success.
Thank you for that. And I totally agree with that. I sit on the board for Perinatal Anxiety and Depression Australia, PANDA. I'm very passionate about perinatal and believe the investment needs to be there very early on. So I'm looking forward to reading that then, Stephen. That's great. We've seen in the past, last week, we've seen a plan released from the federal government. Your plan, your report is about to come, and I look forward to reading the thousands of pages that it will come with. So that's great. I'm just wondering, and it's a question that's been posed here, is do you think that the PC report, and Katherine also, you know, you're doing a review of the Living Well and that kind of stuff. We've seen that mental health funding, and really any funding in to support people, whether that be in housing, employment, is political cycled, and we see, depending on, you know, if you're right there at the right time around election time, it's amazing what can happen. I'm wondering, where do you think that this will make a difference, that governments will really listen and invest in those kind of things and go? I mean, obviously you can't predict that, but I'm just wondering, we have seen the Productivity Commission's reports and other things really make a difference. I think the sector and consumers and carers are eager for it to make a difference. But do you think the politicians will listen?
Okay, so this goes back to something that is often the case with PC reports, and often the case in public policy in general, not just in the healthcare area, but in public policy in all areas. But it's a long game. And you're exactly right that if you get the right recommendations at the right time, the magic happens. And at the same time, there are many, many reports in many, many areas, not just in mental health, sitting on shelves or propping doors open, with great stuff in them. So will this one make a difference? Well, I hope so. If we didn't think we had a chance, if we didn't think we had a shot at it, I'm not sure that we'd be able to get up and do our day jobs. So I think that this has a really, really good shot. I can't guarantee it, but you've sort of got an alignment of the stars happening here. You seem to have federal and state governments who are saying, we need to do something here, that the current mental health system isn't working. And some of that, as I understand, there's some personal history with some politicians relating to this, and that's important because that help means that they understand the issues. So I think we will get a very good reception. One of the risks, COVID-19 has meant a big expenditure of funds. And certainly there has been robust discussion within the Productivity Commission about, well, does that mean that reforms that would have been accepted 6 months ago will now just be shelved because of the cost? Or does it mean that because there's going to be increased mental health problems arising post-lockdown, that there'll be more impetus to take our report, to grab the recommendations, particularly the priority ones, and run with them? I don't know. I hope it's the latter, not the former.
Yeah, I think it is a really interesting time when you consider that we currently have a national cabinet, and that last week they did have an agenda that was about mental health. And I think that for me is like almost the silver lining out of COVID, if we are to find one, is that mental health is on the agenda, and there is a deep commitment. I mean, in New South Wales and in Victoria, both mental health ministers led a combined national meeting of all ministers who had responsibility for mental health. Greg Hunt, the federal minister, was at that meeting, and that's when he said, look, I think we actually need to come together. We're all doing different things. How can we, bring this together? We don't normally do that in a very proactive way. Like, we have a fifth national mental health plan, we have state plans, but we don't always have that holistic plan. And even though COVID may be about a particular aspect, if we're still talking about a sustainable system, which really should be code for a sustainable mental health and well-being of the community, then whether it be COVID and we have focused on the next 12 to 18 months, which is the same if we were planning in a response to bushfires or to areas of drought, and we know the economic fallout. So I think, Stephen, you do have like a bit of the magic recipe here. You've got priorities, you're being fiscally responsible and saying, buy where the dollar's going to get your biggest bang. You can say, we've listened to Australians, and I can give you the numbers to tell you how many Australians have engaged in this, and it makes sense. And I think, it would be wonderful to really see it lift and rise. My only concern is, then how does that then step down to each of those states to map their way through it, and then down to those, regions and communities. So, having some implementation strategy, because it will be fast and quick, won't it? We've seen lots of announcements in New South Wales and other jurisdictions about how they're responding to the drought and how they responded to the bushfire, and now with COVID. So there's been a series of, funding injections and varied in what they look like, whether they be increasing telehealth, whether they be increasing staff in our health services. And as Kathy pointed out yesterday, the Commission and the New South Wales Health Ministry have funded our peak consumer organisation, Beam, to pilot a 6-month warm line for people with lived experience who are doing it a bit tougher during this COVID time. So there's many different ways that we can try and help people. So I think coming back to the thing about being strategic, understanding where those priorities are, but how they mix and link, so you get like a strong matrix. And then my other last point is, and where are people with lived experience in all of that? Where's their input? Where's their guidance? As you said, if there's a metric about what works, that's where their expertise comes in to say, this is what works. So how do we get an accountability framework around that? So for all of this, the people who count most are there to keep us accountable.
Yes, and I'd echo that, Katherine, very much, and thank you for that. And it's a question, leads on to a question that a person in the audience has posed, and we've seen it play out between the Commonwealth and the states around the response around COVID, and how the demarcation of New South Wales, Victoria are going to respond, and so on and so on. What do you think is the appetite of either level of government to let go some of their responsibilities in the national interest and be able to deliver on what you are, the Productivity Commissioner, is going to be advising and recommending?
So, Katherine referred briefly back to our draft report, and obviously our preferred recommendation in the draft report had significant movement of responsibilities to state and territory governments, operationalised through regional commissioning authorities. We've received quite a bit of feedback about the benefits and also the potential risks of that sort of approach. And to give both the PHNs, well, in particular the PHNs their due, they've been quite frank with us about the fact that, look, we've sort of got off to a rocky start, some of us, but, we're getting there. And if you simply come along now and grab the deck of cards and just reshuffle it all again and say, let's start again, with regional commissioning authorities, you may just be setting everything back by 5 years. And I think that was a reasonable point. So I think you'll see change. Well, you will see, I've sort of let the cat out of the bag in some ways in that. You will see changes in that set of recommendations.
So not a knockdown rebuild, but a refurb. Is that what you're putting
Yes.
it away?
Which is what the whole country's doing under COVID, isn't it?
That's right.
I think the starting point's got to be, let's try and get what we've got and what we've invested in, let's try and get it working. And that's going to need some new that's going to need a whole bunch of new structures. That's going to need a hell of a lot more cooperation than has been there in the recent past. When you see things like the National Cabinet working, you sort of think, damn, why can't we do that sort of cooperation for mental health? So I've let the cat out of the bag on that one. That's the direction we've gone down there. But if that doesn't work, and there's got to be targets, there've got to be performance indicators, there's got to be outcome-based performance indicators, where outcomes mean outcomes for consumers. That means that consumers have to be in the decision-making of the relevant organisations, and consumers have to be systematically asked, is this working? Is this helping? And that's got to be the metric that we use. And if it's not working, then we have to go down that harder step and say, look, we've given this a damn good shot. We need more. There's got to be a change of responsibilities, and there's got to be a move towards one level of government having a lot more control and coordination.
I mean, I'm hoping that in what you're saying is that the knockdown rebuild isn't happening, but in terms of it'd be I guess in terms of making sure we're linking those services and the LHDs and the PHNs and the CMOs and all that kind of stuff through systems, and we're not asking consumers and carers to survey them to the cows come home, because I must say that getting surveyed and surveyed and surveyed, and for what really? It isn't person-centred in that way. So I look forward to reading that about that. Sorry, Katherine.
And I was going to say, I absolutely agree, and I think one of the things wherever we went across New South Wales, it was absolutely that integration, coordination, navigation, and I think, and as Stephen said, I had a great service and it was defunded. Or we cannot ever forget the impact of the NDIS. And, some people, NDIS is perfect, but for other people, it was such a system disruptor. It really was very difficult to navigate back in. And I just would have to kind of put my hand up to say also, we tend to, when we talk about things, we forget the Aboriginal medical services, and they are so key to what we do, and especially when we travelled in rural New South Wales. We can talk about LHDs, we talk about PHNs, and we talk about our community managed sector, but the Aboriginal medical services are really need to be totally locked in there. Yeah,
absolutely. One of the questions is around, which I'm interested in, is also around, you mentioned, which is fantastic, Stephen, around psychosocial supports being up front and centre, and very much being, you talked about them for being, on the same par of clinical services, that you won't go, you can't have one without the other, those kind of things. And we've seen over the past few years a few wonderful programs that people continue to still speak today. Consumers who I interact with talk very fondly about Partners in Recovery, FAMS, those type of things. And we know that there's been some kind of replacement in some way whatsoever. But can you give some indication about what the Commission is thinking about in terms of psychosocial supports and the needs there?
Yeah, so I think that, I'm not letting any cats out of the bag with this one, because, post-draft, some of our draft recommendations and the people put to us, well, aren't you just recommending that the government start refunding partners in recovery and FAMs, things like that again. So, yeah, you know, they worked. So I don't think you're going to see radically different recommendations there. The key, though, to creating a community support, including psychosocial support system, is to make sure that the governance, right, is to make sure that you have that regional cooperation, and the cooperation depends on incentives. And so one of the reasons why we feel that the cooperation doesn't exist at the moment is if you put the LHN and the PHN and the LHD in the same room, the LHDs or LHNs have different names in different states. I'll call them LHDs. You put them in the same room and they actually face incentives not to really cooperate with each other. And it really shouldn't surprise us, the difficulties that co-commissioning has had when you have, particularly on the medical side, funding systems that lead to churn in hospitals, where hospitals actually get rewarded when someone gets discharged without appropriate services, and so they end up back in hospital the next week. You know, under an activity-based funding system, they get more money for that than under the block funding for the community services. Well, they don't get paid anymore if that person actually gets the community services that they need. So we just have the wrong incentives. So it shouldn't actually surprise us that the current approaches aren't working when we haven't actually gone down and said, well, what are the incentives that the participants face, particularly on the health side, and how do we change those incentives so they have an incentive to cooperate? So I think you're going to see it's what we call the boring backroom stuff, but unless we get that right, you will not get cooperation.
Oh, that's really refreshing to hear. I look forward to seeing what, but I totally agree with you. And that's from coming from the LHD system myself a few years ago. So I totally understand that. And we have an enormous amount of other questions, but we have 2 minutes left, which is a bummer. Maybe we should have scheduled this for a bit of a longer time. I think from One Door's perspective, we are really hopeful that what we can see through the report that goes to government, and then we'll be able to see once the Parliament is sitting for those, what did you say, 28 days? So I look forward to that.
Well, that's the maximum time. I'm certainly hoping that the government will
release it, but
yeah, earlier than that.
And I think that, you know, it'd be, to be able to see, I think what Katherine was talking about that that implementation following it, the teeth that is going to follow it, and that kind of what I described to the Minister Taylor here a couple of days ago, that, you know, how are we going to step up, show up and do something about it and really make a difference. I know from One Door we're looking forward to that. I want to say thank you to the both of you for your time. I really enjoyed talking to the both of you, and I think we could sit on our virtual couch for another hour. Maybe we'd then translate it into a glass of white or red, but instead of a tea, an Earl Grey tea. I really appreciate your time. I want to say thank you. Is there any final words that the two of you would like to say?
I was just going to reflect on Stephen's comment and just said that, and I think we said this in one of our submissions to the Productivity Commission, that there is the UN Rapporteur on Mental Health who said that the issue really is not about the burden of disease, it's about the burden of obstacles. And I think that's a really great way of seeing it. You know, we keep seeing it in that medical model, that burden of disease. We won't get to the person perspective, which is what's the burden of obstacles that we keep putting in front of people time and time again to get the opportunity to lead the life that they want. And thank you, Stephen. It's been great with both of you to share the virtual couch.
Okay, and yeah, so thank you, Katherine. Thank you, Kathy. Thank you, One Door. And what I really want to just thank again the people with lived experience, the consumers and the carers who shared their stories with us.
Mm.
I've done numerous inquiries over, not just with the PC, but those of you who know my background know that I've been around public policy for quite a long time. You know, you don't get quite the passion looking at an ACCC merger inquiry, or even looking at airports as we've seen in mental health. And really, the stories that we've heard, the personal stories, have taken so much courage for people to present to us, and they've been just fantastic. I can't say any more than that. Hopefully our report is worthy of the input that we have had from the consumers and the carers, because it is unbelievable. And personally, I just want to say thank you so much.
One of the final thoughts that one of our speakers had yesterday, he suggested that each minister and maybe the Prime Minister needs to have a ministerial advisor that's someone with a lived experience as their first and foremost job. I thought that was a really good idea. So maybe you could stick that in there as an agenda. And then just quote Richard Schweizer, and he was great in that reflection.
Can I say, Kathy, I suspect that most ministers already have advisors that either have lived experience or are very close to somebody that has lived experience. Because one of the things that I've realised in this inquiry is that it's actually quite rare that there's somebody who has not been touched, either directly or indirectly, by mental ill health. So maybe it's a case that the ministers should ask around their current advisors, and they may find that there's some very important stories there.
Yeah, but then I think it's about listening and having that roll on.
Yeah, you're not listening.
Yeah, very different.
I agree.
Thank you. I want to thank you both again. To the audience, thank you for being here. Schizophrenia Awareness Week is not over. Tomorrow we have Mind Australia talking about the Caring Fairly study. So that's coming up tomorrow. You can go onto the website to follow that if you want to get on board. And also tomorrow afternoon, I've got Esther from Mostly Mad Music coming on. I'm going to jam with her in the afternoon. Not literally though, I don't play any instruments, but she's going to be joining. And we've got some wonderful musicians who we've brought in remotely. And so I just encourage you to follow the links and get onto that. So we're wanting to support some musicians because we know they've also been hard hit through COVID-19. I want to thank you for your time. Feel free to drop us a line if there's further questions, but thank you all, and have a safe and wonderful afternoon and evening. Thanks, everyone.
Thank you. Bye.
Bye.